Hello, everybody.
Hi.
Good evening. How is
Evening.
everyone?
Good.
Good. Happy Tuesday. Of course, we're going to let everybody join in. Hi. Welcome.
Hey, how are you guys?
We're good. How are you?
Amazing.
I'm a we have a sleeping baby right next to me right now, so I may have to turn my stuff off in just a second, but I'm here.
Fair enough. We're happy to have you.
Thank you. I
Welcome.
appreciate it.
Sleeping babies, you never wake one of those.
She's 3 weeks old today, so
Oh, a little nugget.
we got a couple little life changes happening pretty soon. So
I would I would say.
yeah, but she's been great.
Awesome. Oh man. I remember those days. Yeah.
Life is upside down a little bit, but that's okay in the best possible way.
I'm sure. Those first 3 months are just, pure survival mode for
That's
everybody.
right. She hasn't figured out the whole sleeping thing yet, and I think that'll take some time.
Yeah. I mean, I have an 8-year-old and he hasn't quite figured out
Don't tell me that.
the my pediatrician was like, you either get a good sleeper or you don't. He's like the parents of the really good sleeping babies are like, we're so magical and we get the baby to sleep. He's like, you get what you get.
She slept for like 5 to 6 hours last night in the stent, so I'll take what I can get.
You are already on a winning track, my friend.
I
Uh,
hope so. We'll keep up the momentum.
I love it. Good. Yeah, my 8-year-old gets up by 5 a.m. every day of his life.
Oh, I can't wait.
Yeah, he's just always been that way. It doesn't matter what time he goes to bed. Trust me, we've done the whole like, let's put him to bed a little later and see what happens. No, nothing happens. Nothing happens with the same early morning. But
He gets more and more sleep deprived, and you get more frustrated, I'm sure.
yeah, so he goes to bed early and just gets up early. But my dad's the same way. So, hey, Madison, you don't have.
Hey, Dr. Estes, good to see ya.
How are you?
Good, good. Can't complain.
Love it. You guys had a great CE event last Friday.
Yes, it was a great lecture, a lot of good pearls. Yeah, we were happy to have them.
Love it. I listened in a little bit as much as I could.
Mm,
And
yeah, we did
you talking about accessing number 8 from the facial. I was like, whoa.
mm-hmm.
I don't know about that. But I get it. But it's a brave move right there.
Mm-hmm. Mm-hmm. I thought the apical scrub thing too was interesting that he does. I feel like that is definitely an art to establish. But yeah, it was
A
cool.
lot of
Learned a
art
lot.
to do, right?
Mm-hmm.
True. And every artist is their own.
Mm-hmm.
So of course we'll wait a couple minutes. We'll let a couple more people join in. It's just 8 o'clock now. So we'll give everybody a teeny wiggle room here. If you're like me, when it's time to find the Zoom link, you're like, "Whoa!" That's basically how it goes. Whoa, where's my link? And of course, I don't start looking until it's like 2 minutes before, and then I have straight up panic mode. So, hey, Brad.
Hello, everyone. I just was planning my Zoom meeting and everything, so I got in, and I
Good.
was like, I need to fix my audio. So,
There you
hi,
go.
everyone. So,
You weren't Zoom panicking like I was talking.
yeah, I think it was perfect timing because I was like, oh, I understand what she's mean by that.
Where's the link? Well, good. We should have a few more, so we'll be patient. But anybody believe that it's Thanksgiving next week? That's wild. I said to a patient like yesterday, I was like, "Happy holidays." It felt so wrong, but I mean, it is, I guess.
Yeah, it's flying.
I know. And then once you get to this point of the year, it's like, pooh, the rest of the year is just she gone. but all good stuff. All right, we have Ryan joined. Welcome, Ryan. Love it. We'll get everybody situated. Hello, look at that. See, the room be filling up. I like it. Brave souls to turn on your cameras. I like that. All right. Hello. The general wave. Hello over there. Awesome. Okay, so before we start, I want to talk a tiny bit about my shirt. It says dental, I can't even, how do I show this? Dental Impact Summit, which I'm just going to give a shout out to Tower Leadership, which is a really fantastic organization that I joined this year. And they are all about, you know, growing dental practices, being support, basically for all your growth needs in a practice, but huge focus obviously by the name of Tower Leadership. And they believe that the success of every practice is based on leadership. And I completely agree. And me, Lisa's up there in the corner. Wave, Lisa, my right hand. We went to, they have an event called the Summit, and we went this past week, and it was just a fantastic event, just some really motivating speakers, great people in the dental industry and outside of the dental industry, and just a really great group of people in a room to be in that's motivating and inspiring. And at the summit, so this was our first time going since it was our first year, so we didn't know exactly what to expect. And at the end of the 2 awesome days, they have a couple awards that they give out, and one is for a practice that has a ton of contribution to their community, which I think is really fantastic, right? So some people do some really great give backs and just lots of integration with the community. So that was one of the awards. One was for a practice and doctor that exemplified great leadership. And then the third one, or the big one they called it, was like the Practice of the Year award. And so for this is for a practice that's, you know, really kind of embraced all of their philosophies and the tools and everything like that. And so we're sitting there, and I brought Lisa and Emily, who are kind of my right and left hand in practice, and we're enjoying the awards. And I turn to Lisa and I say, one day we're going to be up on that stage. Like, that's going to be us up there. So this was right before they started the Practice of the Year. And so they start to announce and describe the practice of the year that's getting the award. And I'm sitting there and I'm like, wow, like, this is a great practice. Well, it happened to be my practice, and they announced the Innovative Endodontics. I mean, I couldn't even, I was blown over. Like, I just didn't even expect it. But I bring that up to say that, you know, truly proud of it, and never thought that we would earn that in the first year of participating with this awesome organization. But I just think it's really relevant when we talk about, you know, private practice and the types of opportunities that we're looking for, because it's very important to choose a practice that does believe in the right things and support the right things. And so we're just like super proud of that, and totally overwhelmed still, so a little bit. But just, you know, when you're researching opportunities and talking to practices and doctors, you know, have in the back of your mind all these really important things that make your day-to-day life as good as it can be. So cool. All right. So for those who might be new, we're going to talk today. I'm going to pull up my presentation. This is intended to be for you, right? So this whole point, for those who might be new, is that I, you know, in having had some conversations with some graduating endodontists, you know, there were some conversations that I thought, you know, we could have asked better questions, right? So it's not about what files you use. It's not about your irrigation protocol. Like your success in practice really is dependent upon the types of questions you ask before you join that practice. And so I felt like there was a little bit of a gap. We all know that we don't get enough business education in dental school or residency, and that is unfortunately quite true. But we also don't get a ton of guidance aside from maybe a faculty member or something about private practice and what should we be asking about before we join. And so this is like my little kind of contribution to the things I've learned as a business owner, as well as having associates, and some of the things that I've learned throughout that process. So today's intended for you all, to try and get some good info out of it. So Miss Lisa is going to be monitoring the chat. So if you have a relevant chat question that you would like asked at a particular point, send it to her. She can give me the interruption and I can answer it. We also, of course, will take questions at the end. So whatever works best. And the topic for tonight is private practice pitfalls. So basically, when we come into private practice, there's a whole lot that's like really different than okay, there's a whole lot of life that's very different in private practice than in residency, and each and every single one of us is going to make mistakes. But if we can share the mistakes and learn from them, then maybe we don't all have to make the same mistake, right? I think that's a pretty cool thing, is to not repeat mistakes if we don't have to. So that's the topic of tonight, and we're going to go through this. Like I said, interrupt if you need to. Happy to answer all your questions. So adjusting from residency to private practice. So a little bit about my story. Look at me, that little baby face. That was at MUSC in that room that some of you have spent a lot of time in. And that's my really good friend, Elena. And of course we had coffee, because what's residency without coffee? But I feel like there's a little baby face there, and then, oh my goodness, I'm in private practice. So it happens just like that. It went very quickly. My story was, I didn't necessarily intend to open my own practice. I actually was hoping for an associating opportunity after residency, but we had moved a lot in a short period of time. So I had taken a Navy scholarship to pay for dental school. So we moved from Boston out to California. I deployed to Afghanistan. Then we were in Jacksonville, Florida. Then I came to Charleston for residency. So there was just a ton of movement in a very brief period of time. And my husband and I were like, enough moving. We want to set some roots. And we love Charleston, because what's not to love about Charleston? And so we wanted to stay. And so that meant I was looking for associating opportunities. And Charleston's a pretty small city. And so most of the endodontists here were, solo single providers that couldn't support necessarily a full-time endodontist associate. And so it quickly became clear that if we wanted to stay, then I was going to have to open my own practice. Either that or we were going to move. And so I was like, sure, let's do this. So I opened a practice right out of residency, which, is all sorts of crazy. But I think I went into it with a great mindset, in that I always believed, and I still believe, that if you treat people well, whether that's your patients, your team, your referring offices, if you treat people well, you will be successful. And I think that's very true. And so, yes, I had a lot to learn, and it was like drinking from a fire hose at times. But I really knew deep down that I could do it, and I was open to learning and getting better. So adjusting from residency to private practice was just an enormous undertaking, because I had to learn everything from hiring and firing and managing people and understanding insurance and billing and profit and loss, and I mean, just a ton. And so I've learned a lot. And so that is why I want to share, mistakes are a powerful teacher, right? And we shouldn't be scared of mistakes, because failure, I mean, is one of the greatest teachers in life. So sometimes people, are just so fearful of doing something wrong that you just aren't your true self. And so just understand that as hard as you're going to try in private practice, and we're always trying to do the best for our patients and our team and our referring offices, there are going to be things that just maybe don't go the way we hope that they would. But it's going to be how we handle those things that are going to distinguish you from somebody else. And so don't be afraid of the mistakes, because they're going to happen. But we'll talk a little bit about maybe some ways to proactively address the situation. So what are some things you're going to learn today? We're going to talk specifically about communication and confidence pitfalls. Okay, huge topic in my opinion. Clinical and diagnostic pitfalls, business and practice pitfalls, and then relationship and culture. So those are going to be the topics. We'll kind of dive into each one with some more detail. And so the first is communication and confidence pitfalls. So I will say that I think communication might be one of the most important skills that any doctor can learn. Okay, so some of us are naturally stronger communicators, some of us not so much. But I will say that I think communication in all circumstances is just an incredible skill set. And if you don't feel as though you're a strong communicator, we really got to strengthen that, because your communication ability is going to set you apart from so many other providers. I could say the same thing as Dr. Smith, but how I say it, how clear it is, how it's conveyed to the patient can make all the difference. And that's true with referring office relationships, because marketing and referrals are all about relationships. And so if that doctor thinks that they can ask you that question honestly, or can pose a concern, and they can communicate with you, that's going to only strengthen those relationships. And communication happens to be one of our practice's core values, because I think it's just so incredibly important. So confidence and clarity builds trust with patients and referring doctors. So we're going to get into details about that, specifically presenting treatment. Okay, so when we present treatment, we have to present it confidently. Now, this is not stating that there aren't going to be some complex cases that maybe have a more guarded prognosis or might have more than one option, right? There's always going to be those circumstances, but it's how you present the case to the patient that is going to determine the outcome. So first of all, uncertainty erodes patient trust. So if you come into your case presentation or consult or whatever you want to call it with the patient, and you aren't just very clear with the patient, immediately they're losing trust. Okay, so if you're like, well, we could do this, but we could also do that, and studies show this, and on the other side, patients, trust me, do not care about the studies. We have to remember that we always have to talk at the patient's level. So if you are doing a case presentation and routinely using words like irreversible pulpitis, it's gone. They don't understand what that means. They don't frankly care. They want to know, is the tooth healthy? What do they need to do? That's it. And people in general want you to tell them what to do. They really do. They're coming to you as the specialist. They want you to assess their case, and they want you to tell them what to do. And the way I achieve this is I always look at the cone beam before I go into the room. So my team takes the cone beam, the patient is sat, my dental assistant is gathering the history, right? So they're asking all the questions. What are the signs? What are the symptoms? When did it start? All the stuff. And while they're having that conversation, I'm looking at the cone beam. And let's be honest, 8 out of 10 times, the cone beam is a really great indicator of what's going on. And probably you're already deciding what you're going to do in the case before you've even seen the patient. My dental assistant comes in, gives me the backup information. So really, I'm going into the case with tons of information already. Of course, we have to do sensitivity testing, and so we're not relying just on radiographs, but let's be truthful that we probably already have a pretty good idea of what's going on. And so that means we can enter that conversation informed. So when you go into the room, I always like feed back the information that my dental assistant gave me. I'm not going to ask the patient the same questions again because they're like, well, I just told that lady that this, and this happened. So I'm going to go in, and instead of asking them the same questions, I'm going to tell it back to them and confirm that it's accurate. Now, sometimes they might be like, oh, no, it's not sensitive to cold, sensitive to heat, whatever. They might correct a little bit. But if you go in and you're like, welcome, Miss Jones. I'm Dr. Estes. We're so happy to have you. We're going to take great care of you today. First of all, before I'm even talking about teeth or symptoms or anything, you have to establish rapport with patients. And you have to do it very quickly. So these patients are used to seeing their general dentist every 6 months for their cleaning. So their dentist knows all the things about them. They've been going there for 20 years, but they're just meeting you. And, they don't love having to go outside of their comfort zone of their general dentist, but here they are. And so, before launching into tooth talk, you really have to establish some, a relationship with them, and a warm welcoming greeting goes a long way. I would say that you should be eye to eye with patients. So, having the eye contact, certainly not, in sitting behind them in your chair where they can't even see you. You have to establish eye contact. You have to have those social skills to be able to recognize if they're nervous or not, which a lot of our patients are, so just reassuring if you get the sense that they're nervous, like, we are going to take such great care of you. You came to the right place. Whatever those value statements are, those are called value statements. So things that you're saying to the patient, each and every patient, to build rapport and trust with them. You have to be able to have those and relay them confidently. So once you've kind of established relationship, then you can start talking tooth. And so at that point, I say, so I understand that you've had symptoms on the lower right for about 2 weeks now. Your chief complaint, or the thing that bothers it most, is cold sensitivity. You also sometimes don't chew crunchy foods over there. And you had a filling placed about 3 months ago. Is that correct? And so, right. So I'm not making them say it again and again and again. I'm just reiterating the information that I already have. That way the patient's like, yes, that is what I said. They're listening to me, right? So that builds some trust there as well. And then I always say to the patient, here's what we're going to do first. The first thing we're going to do is some gentle testing. So everything in practice has to be gentle, has to seem very benign and not scary. So we're going to do some gentle testing, which is going to tell me a lot of information about what's going on inside of your tooth. Then we're going to talk about the 3-dimensional picture of your tooth that we took, and we'll discuss what we should do. Does that sound okay with you? And then the patient's like, yeah. So they're buying into the process, right? So you're explaining what's happening. They're on board for the journey. You've already had some opportunity to talk before you're sitting them back in a position that's, intimidating of patients. And then, I'm kind of going on a tiny tangent, but like, once you start to do your sensitivity testing, it's really important, in my opinion, to do the contralateral side. So you have to establish normal for that patient. So if the chief complaints on the right side and you hop into the right side, you don't really have a normal to compare against. For some people, some people are jumpy, and so everything hurts, right? But what is their normal? Are they super sensitive to cold on every tooth? If you don't have a normal baseline, then how are you really comparing for pathology? So don't forget to train your patient and explain. They don't do sensitivity testing. They don't know what it's all about. So making sure that you say, first, we're going to go to your left side so that we can establish what's normal for you. And I always make the joke, because these tests can be a little bit weird. It's not every day you get your teeth tapped on, and just to give them okay, so I tap, tap, tap. So that's normal for you. So now we're going to go to the opposite side, and I'm going to do the same thing. And you're going to let me know if there is any difference. If a tooth is sore, tender, or different, I want to know that. So now I'm training the patient, for them to understand the difference. So always making sure you have a baseline, I think, is very, very important. And also in terms of creating confidence, they can see the difference too, right? So they're like, oh yeah, that feels very different than my other side. So that's helping them build an understanding in, yes, there is a distinguished difference. So there is something going on. But if you're not using the normal, then they might just think everything hurts. So I think it's important to kind of walk the patient clearly through that. So once you get your, your findings, your case presentation to the patient has to be really clear. It has to be very crisp, very clear. I always have my cone beam, a slice, maybe not the whole thing because that can be overwhelming, but if there's a slice that looks really clear to me that they could understand, I put that up on a TV. And they're looking right at it. And so I'm near the TV. I'm talking about, what I'm seeing on the tooth, and they can follow along, right? So you don't have to be an endodontist to see bone loss, right? Because you can show them what normal bone looks like, and you see how this is dark and this is different, right? So just using layman's terms, do not throw out symptomatic apical periodontitis. Just don't do it, because that gets patients very overwhelmed when they start to not understand the verbiage that you're using. So keep it as normal. You can use words like pressure. I don't use the word pain ever. That's a bad word in my mind, because everybody also already associates root canals with pain. So we might say discomfort, we might say soreness, but I don't like the word pain. I think that that's a naughty word. So I don't use that word. I try and find alternatives or more gentle words to use with patients, just to kind of keep the anxiety low. But, in terms of how you're presenting, I understand that there might be option A, B, and C in a case. I get it. But you need to present one. You need to pick one, and you need to present it, and you need to say to the patient, this is what I think we should do. Now you can say alternatively, you could have the tooth removed, and maybe you're kind of presenting that, but don't do the whole option A, option B, option C. Like, they don't frankly, want to hear all of that, because at the end of it, they're going to go, okay, so what should I do? Right? Because that's what they want to know. So, of course, there's informed consent, but don't go down the rabbit hole of options. If you really think that a case is going to be successful with whatever treatment that you're recommending, own it and recommend it. Because if they get the sense that you're unsure, guess what? They're not going to schedule, guaranteed. And, if you're in a practice that tracks referrals and case conversion, which hopefully you are, there's a huge difference between, say, owner experienced provider and traditionally a new associate. The number of cases an experienced provider closes or schedules, and I'm not talking about unnecessary treatment. I'm talking about treatment that needs to be done, ethically. But it could need to be done for both case presentations, but one gets the patient to schedule and one doesn't. And why is that? And it's usually just how you come across to the patient. And there is a very clear difference traditionally with newer providers. And I'm not saying this is, a bad thing. I think we all go through that kind of confidence building stage, but the faster you can work on that, obviously the fuller your schedule will be, and you're going to find less and less difficult conversations with patients, because they're going to feel your confidence and they're going to go with what you recommend. So uncertainty is a no-no. Like, you need to present it. This is what I would do, and come across very clear. So I hope that's helpful. I think that is one of the biggest things I noted with new associate doctors, is just that level of hesitation. And it's natural, but we have to kind of work through that. And if that's role playing with other doctors, and the other doctor could pretend to be the patient and ask some questions, I think that's great, because then when you're in the real situation, you're going to find it a little bit easier. So uncertainty is super important. You got to come across confidence. So confidence communicates competence, right? And even if a case is complex, we have to always be that specialist, because that's who we are, right? If their general dentist knew what to do or could handle it, they wouldn't be in our chair. So we have to understand that we are the specialist, and we need to present ourselves as such. And patients say yes when they sense clarity and assurance. So I will say, very confidently that my patients schedule with me, because I come in, I tell them what's up, I answer the questions, talk on their level. And it's a great thing, because they walk away feeling confident in what's going to be the outcome. So
Dr. Estes, will you give just a quick, I know we went into a lot there, but
Yes,
just
sir.
a quick example. So let's say you have a case that has a good prognosis. Will you kind of pitch what you're saying to that patient confidently in terms of telling them they need a root canal?
Oh, amen. Yes. Yes.
You've done it before.
So yes, so it is Miss Jones, a kind of a brief explanation of, that sensitivity you're having to cold, that's a sign of inflammation. And once that starts in a tooth, unfortunately, there's nothing that your body can do to fix that. And there's no magical pill or anything. So your options are root canal treatment or extraction. I strongly recommend a root canal. Root canals are very predictably successful. That is all we do all day, every day here. That is our specialty. We are going to take amazing care of you. It is nothing more than getting a fill-in. So we're going to get you super numb and comfortable, and we'll get you in and out of here in less than an hour. I expect you to do great. So when you present it like that, they're like, oh, okay, right? Like, great. So yes, your presentation is, this is what I recommend. I do often, like, if I know they're going to need a crown, I say, and then you'll return to your general dentist and you'll get a crown on the tooth to protect the tooth. So I do want to make sure that's clear in the presentation as well, because I don't know how much their general dentist has said or not said. And so you are going to get a spectrum of patients, some of that are super prepared for, basically their general dentist has educated them and told them, what a root canal is, and then explain they'll go back for the crown. So some kind of get it. And then others feel like they're hearing it for the first time. So you are going to get a spectrum of preparedness from your patients. So just making sure that we are kind of painting that big picture, but very clearly and quickly. Because it's not fun if the patient's like, well, nobody told me I needed a crown. Well, that's part of this diagnosis and letting you know the steps. We'll do the root canal here, then you'll return to your general dentist for the crown. And then they know the information. So, woo, excuse me. I got so excited there. But yes, you have to tell the patient very clearly, this is what I recommend. I also think it's important to create some urgency with patients, so, sometimes patients are like, well, it just hurts a little. And you have to explain to patients, pain does not always equal pathology, right? So just because something doesn't hurt, I always say, doesn't mean it won't hurt tomorrow or next week or next month. It will hurt at some point, and the sooner we can address it is always better. And I always kind of joke, when the tooth wakes up, it's going to be a weekend or a holiday. So strongly encourage you to pursue treatment before that happens. So you have to create some urgency with patients. You're not scaring them to death, but if there's pathology, we all very well know that there will be symptoms, right? And delay or procrastination on their behalf ends up a 5 o'clock emergency on our behalf because they didn't do the treatment 3 months ago when we first recommended it. Now, I will say, in terms of scheduling, if and when I can, and it's quite often, I like to do the handoff. We call it the handoff to our front desk or coordinators, the scheduling coordinators. If and when possible, I like to walk that patient out and hand them off verbally to the coordinator. So why do I do that? Number one, because have you ever been at a doctor's office that they actually, walk you out and say, it was so great to meet you, I look forward to seeing you soon. That kind of customer service and rapport with the patient. Most practices are not doing that. They're having a dental assistant or somebody else walk the patient out. So I think it's an opportunity to stand out. But also, in the handoff, I can say, I'm recommending a root canal number 14 for Miss Jones. I'd really love to see her at my soonest available. So in handing them off, now I've set up my scheduling team to be like, all right, Miss Jones, well, Dr. Estes would really like to see you. Her next opening is. And so it's kind of greasing that scheduling component, because sometimes, how they act with us and how they act with the rest of the team are not always the same. And so if you hand them off, then your scheduling coordinators don't have to play that game of like, they're like, well, I'm going to, let's schedule for 2 months from now. well, that's certainly not what I recommended, right? And so if they hear me say it to the scheduler, then it's basically helping kind of facilitate what's an appropriate next step. So I think that's a huge part of getting patients to schedule as well, is clarifying that, yes, there is some urgency, and we'd love to see them soon. So kind of that whole process, from the meet, the greet, the establishing, to very clear communication, to sensitivity testing involving opposite side baseline, always making sure after your case presentation, do you have any questions? Is there anything I can clarify? Giving them the opportunity to ask the questions. You know, a nice warm close of like, we're going to take great care of you. I hope to see you back soon. Let's walk you out to my team up front and they can go over the details with you. So that whole process, I think, you know, doing a diagnostic evaluation and case presentation is a skill, and you have to practice it, in my opinion. And I would, you know, a lot of other doctors, if you can, if you have access to other providers, because from an outside perspective, you will pick up on, you know, maybe words they use or don't use, how strongly it's being conveyed to the patient, how receptive is the patient. So you want to see the good and the bad, right? So if you can see multiple doctors with case presentation, you'll be able to pick up on, well, what do I want my case presentation to be like? And so you can kind of take tips or tricks from multiple providers. But I would pay very close attention to posture and mannerisms and positioning, and all of those things are very important. Yeah? Having fun yet? Okay. So the next topic is avoiding or mishandling money conversations. All right. So it is very much my opinion, I don't talk money. Like I'm not here to talk money. This isn't about money. This is about what your clinical needs are. And I am presenting treatment with no, you know, like it is not dependent upon money, right? So I'm not, you know, for this patient recommending this and this patient recommending that. Of course not. So I don't want to talk money. And frankly, you know, like I know the least probably about like what our fees are. And, you know, like I just don't want to have that conversation with patients, because we have trained team members that are so fantastic at this. So this is not our place. If a patient asks, okay, well, how much it costs, I say, absolutely. That's an important part of this conversation. I'm going to have my team go over the treatment plan with you, and they will answer all of those questions. You know, I might throw in, we also have financing options available to you, and they can go over all of those details, because we want to make it as easy as possible for you to schedule, you know, so like something just along those lines of, I'm not going to be the one to have the conversation, but we will happily have that conversation with you. And I think, you know, talking money, that shouldn't be on your plate at all. That should be handled by your team. Obviously, a practice should have very clear systems as to what do we traditionally charge and when. Like this shouldn't be something you're deciding. Like there should be clear protocols and systems already in place that are being implemented for each and every patient. I will say that what we call financial transparency is very important for every single patient. They need to understand what to expect. So if you are not setting expectations early, you're going to end up with a frustrated patient. So what do I mean by that? You know, if you participate with insurance, there should be someone on your team who can accurately assess insurance benefits for that patient and provide what we call an oral health investment. Okay, so it's not a copay or out of pocket, like those words have a lot of negative connotation. So an oral health investment, that's what they're doing, right? They're investing in their oral health. And so prior to them even getting time on our treatment schedule, those financial conversations need to be had. Number one, we don't want them showing up and being surprised by a big number that maybe they weren't expecting. Number two, we need to protect our treatment time. So unfortunately, if there's going to be someone who needs time to plan or research financing, whatever that might be, that's fine. But we can't sacrifice our schedule time if that's not kind of addressed up front and before day of service. That is not a conversation we're having on day up. So if you set the expectations very clearly, and then we follow through with what we said we would do, then you don't have upset patients. Now, I will tell you, if you were to go to the vast majority of dental practice Google reviews and you go look at those 1-star reviews, the vast majority of the time, it's all about the money. Okay, so frankly, most patients don't understand dental insurance at all. Very, very different than medical insurance, as we know, but most patients just kind of lump them together, don't really understand maximums and write-offs, and they don't get it. And so you need to have a compassionate team who is willing to educate the patient and explain how they got to this number, and clarifying this isn't our office, this is a reflection of your own insurance policy. So having those conversations, because if a patient that doesn't know ahead of time and no one explained it to them, that's where the frustration comes. And so that's where bad Google reviews come. I guarantee it. If you go look at practice reviews, a lot of times it's money. And so we have a lot of control over that with how proactive we are in preparing that patient for their visit. So again, this is not me doing this, but you better have a very well-oiled machine of a team that understands this and is doing this for each and every patient visit. And then, there is a real, expense. This is not something that they were expecting, right? They didn't think they were going to wake up and need a root canal this week. And so, being empathetic with patients, trying to, be compassionate. I do not advise doing in-house payment plans. This is not the whole, my heart is, bleeding for this patient, so we're going to let them pay over 3 months. Like, there is compassion there, but that is why you engage with financing options. Okay, because that's exactly what these companies do, is they vet the patient and they make sure that they feel as though they'd be able to pay them back. Now, if they don't qualify for, we use Cherry, Sunbit, and Care Credit in our practice. We're favoring Cherry these days, which has like a really fantastic over 85% approval rating for patients. So if Cherry, as a financial institution, does not approve this patient, they're saying, we know we're not going to ever get our money from this patient, right? So why would I, Dr. Estes, who is not a bank, I'm not a financial institution, why would I say, you know what, let's do this root canal for free and really hope that Ms. Jones pays me? Like, that's a silly business decision. So again, being empathetic, but securing finances, they can go hand in hand. That's why we discuss financing options with patients, and we're very clear with educating what their options are. But don't start to go down the rabbit hole of talking money. I think that's not the appropriate place for a doctor to be. That's not their role. So we all have a role, but that's not ours. All right, moving on, next topic. So failing to address an unhappy patient promptly. All right, so let's be real. There are always going to be, as I alluded to at the beginning, there are going to be situations, cases, people, whatever it is going to be, where someone's unhappy. It's just going to happen. I mean, the best practices in the whole wide world have this, right? There are just difficult patients, difficult circumstances. Hopefully they're very few and far between. This should not be a routine thing in practice, but I'm telling you, they're going to happen. And so we shouldn't be surprised when they do happen. But it is exactly how we handle that situation when it occurs that makes all the difference. So delaying a response. So sometimes we're like, they left, whatever, sweep it under the rug, I'm sure it'll just go away. That is not going to happen. Okay, right? That is not what happens. It usually escalates. The patient's version of events gets bigger and bolder and whatever, right? So the most appropriate way to handle an unhappy patient situation is promptly. Okay, so in my practice, I have a fantastic Lisa, right? So Lisa is, a professional relationship coordinator. So her entire role is marketing, as well as being the person who gets to handle and diffuse any and all situations. Again, very rare, not something common in our practice, thankfully, but she is the person and she is skilled at that. She has a very understanding, and very sweet tone, and she's empathetic. And so most of the times patients just want you to listen to them, right? They just want to be heard. And so whether that's Lisa just, right? Like that's all it is. She's just being empathetic and compassionate. She's listening. But also, we of course want to make every patient happy, but we also have to be very cautious of our referring office, right? Because they are the lifeblood of our practice. We want to keep referring offices happy. And so if there's a situation, we have to communicate with the office appropriately. Again, Lisa is strong at doing that. She has relationships with office managers, but she's getting ahead of the situation, right? So I want the referring office, if there's something awry, whatever it might have been, I want that referring office to hear it from me, my team first. We have Miss Jones today. She presented for treatment and, she was displeased with her out of pocket, blah, 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 whatever. But we want to have the conversation with the office first so that when the patient does call or comment the next time they come in or whatever that looks like, they're not caught off guard, right? Because they send patients to us knowing, hey, you're going to get taken care of over there. They're going to be wonderful. And if that's not what the patient receives, then that starts to erode their confidence with us as a practice. And so we need to be very clear and communicative with them so that we're just addressing it. This is what happened, and we're always saying we're happy to see Miss Jones back if she changes her mind about treatment or whatever the situation might be. Documenting it in your notes is very important, but really getting ahead of it so that you have set the stage of this happened. This is what we did. If there's anything else that we can do to be of assistance, please let us know. That's what the office wants, right? But they don't want to send a patient to you and get a headache. And then they send another patient next week and there's a new headache, right? So there better be very few and in between challenges or issues because they want to send it to the practice that makes their life the easiest. And so if they send a patient to your practice and time and again, there's a challenge or an issue or a question or a complaint, guess what? The referrals shall stop, right? They're going to go somewhere else. So, delaying a response is not great. I will say in our practice, if there's anything less than a 5-star customer experience, that is handled before the end of the day. We do not go home. There's nobody going home and putting their head on their pillow at night if there was a patient that had anything but a stellar experience. So that's how we handle things. We do it very clearly and promptly. And I would suggest that you do as well. So making sure you're documenting, there should be accountability and learning as well. So if it were something that were preventable or something that a team member could have done better or said better or whatever it was, it's an opportunity to train our team. So if you see a team member kind of make an error or mistake that resulted in an unhappy patient, that's your opportunity to kind of retrain your team. And it's not a bad thing, but we don't want the same mistake to happen again. So you have to recognize, okay, well, what was the foundational issue? And what could we have done better next time? Again, it's all how you train your team and present it. You're not coming down on them and getting upset, but it's what can we learn from this to do better next time? So making sure that your team is being accountable and learning again. Always being empathetic. So, right, just being very, listening. It's all about listening and just trying to diffuse the situation. And of course, we are always being professional, right? So this is not, we go apply to their Google review all mad, that is not showing professionalism. So we are the providers, we are doctors, we are held to a different standard. So even if it doesn't feel like they're right, we have to sometimes smile and work through it, okay? Because it's not about he said, she said, and who's right. It's about what's best for the practice. And so don't get into one of those, situations with a patient because nobody wins in those, okay? So sometimes you just smile. Okay. Not protecting the referring doctor. So this is really important. So, the referring doctor sent the patient to you. And sometimes there's some missing information, right? So such as, Like you might look at a tooth and it has a crown and it needs a root canal. And you might say, so we're going to do the root canal and then we'll send you back to Dr. Jones and he can put the filling in the crown and you'll be good to go. And then they're like, oh, well, Dr. Jones told me I need a new crown. Are you saying I don't need a new crown? Because he told me I need a new crown, but if I don't need a new crown, I'd rather not get a new crown. And whoa, what has just happened, right? That doctor already has their treatment plan and you just, like blurted something out without knowing the information about their treatment plan. And now you have a patient that's questioning their recommendation. And is going to go back and be like, well, Dr. Estes said, like, I don't need a new crown. So blah, 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 right? That's not a position you want to be in. That is not good because you are not protecting them. You're not supporting them. So I ask the patient a lot of questions before I say anything. So if the tooth does have a crown, I mean, sometimes there's clear decay and there's a recommendation for a new crown, but sometimes I don't know what they recommended. There's no like clear decay. So I'm not really sure what the plan is. And so I'll say, did Dr. Jones talk to you about whether or not he's recommending a new crown on this tooth? And sometimes they'll be like, yep, he's planning, I'm going to be going back in 2 weeks for a crown. Great. So there's no part of me that is going to say something contradictory to that treatment plan. That is not my place to make that call. Or they might say, well, I don't know if he's recommending a new crown. I'm not really sure. Again, I'm not going to infuse I'm not the restorative doctor. So I'm going to say less, right? Less is more. So what I might say is, well, what they're going to do when you go back is they'll assess the crown and they're either going to recommend a new crown or they might recommend to maintain the crown and put a filling in there. But Dr. Jones, as the restorability specialist, is going to be the one to make that decision. So I don't know what their decision will be, but I'm supporting it, right? So sometimes just not saying anything unless you have little information, because once it comes out, it's Pandora's box and it's out there and the patient, can try and pin what you're saying against them. You don't want to be in that position. If anything, you want to ask them what they know about the next step for the particular tooth. What did Dr. Jones say? And if you don't know or they didn't know, you're just being very vague. Okay. This, I think, is something that newer docs, sometimes I know we talk about restorability and all that in residency. We're not that person. We're not we're not putting crowns on. So we have to respect the general dentist and their role. And if you contradict their treatment plan, it makes them very displeased. So don't do that. Okay. Frame comments in terms of shared goals for the patient care. So we're always talking about, the best of the patient, long-term, so if and when there's an opportunity to compliment the referring doctor, you should always take that opportunity. Oh, we love working with Dr. Riley. He and his team are so fantastic. And we love his patients. So that's a great thing to say in general. But then they go back and they're like, oh, Dr. Estes says she loves you. Do you think your general dentist wants to hear that? Of course they do, right? So always making sure that, Dr. Riley and I, we're always on the same page and, blah, blah, blah. So just always framing comments positively. And just, I know I kind of have gone over this, but protecting your referring relationships, right? So just be aware and be mindful of what you're saying. You certainly just don't want to ever make a comment like, who knows, maybe the original root canal was done by that doctor. Might be a terrible root canal. Not your place to say this is a terrible root canal, right? Like, because you don't know the history, and saying less is better. So unless it's positive and complimentary, I would just be quite mindful about the actual words that you use. All right. So not alerting the owner doctor if a case didn't go smoothly. All right. So this is going to happen, right? Life is going to happen. If you do enough teeth, there's going to be a separated file. If you do enough teeth, there's going to be a perforation. It's going to happen. Again, it should be really infrequently, but it will happen. And let me tell you, as an owner doctor, there is nothing more frustrating than finding out about this 10 steps down the road. Okay, because I am the one who created the initial relationships with these offices. I'm the one who's built those, and I need to protect those. And if I don't know that something didn't go the way I wanted it, we wanted it to, then I can't address the situation promptly. So this is not again, put it under the rug, it's going to go away, patient's not going to say anything. That's not true. Okay, so I need to know, and it's not to, be displeased or upset or whatever. It's because we have to protect the referring relationship. And so I need to know as soon as possible if something wasn't perfect. Right? So maintaining transparency and accountability with the team, that includes your owner doctor. There's areas for process and clinical improvement, right? So it's an opportunity if a case doesn't go great to okay, let's talk through that. How is your access, and why do you think that you were kind of unclear where you were in the tooth, or whatever that is? It's an opportunity to learn from. Again, if we're not learning from our failures, we're missing a fantastic opportunity. So you hopefully have an owner doctor that you can discuss cases with, but don't only discuss your great ones, discuss the challenging ones, because you're going to learn way more from those. So it's an opportunity for improvement. And of course, it's integrity, owning, hey, this case didn't go the way I wanted it to. And of course, we all have those feelings of guilt if something doesn't go great. But at the end of the day, as long as we're learning from them and it's an opportunity to get better and they don't continue to happen, it's part of our learning process and experience. So, be professional, communicate honestly with your owner doctor, so that they can help you get through that and protect the referral office as well. All right, so we're going to go into little clinical and diagnostic pitfalls. So technical skills, really important, okay? But so is judgment and adaptability, okay? So here is one thing I learned from a previous associate doctor is we cling to what we learned in residency, okay? We're just stuck like glue to what we learned in residency. And we learned great things, right? We did. We learned great things. We learned textbook, this is how you do it from a textbook standpoint, of course. However, there's real world, okay? And private practice is real world dentistry. It is not residency anymore. And so we have to be open to new techniques, materials, workflows. Okay, so I would strongly discourage you from going into a practice and saying, I can only use this file. I'm only going to use this. I need this sealer. I need that's just maybe a little short-sighted to say, this practice has been doing this for a decade. They're very successful. Maybe they have something else that I could learn or they could offer me from my knowledge base. So of course, we learn things in residency and we get our comfort zone with different things, but just being open, right? Being open to, okay, well, what did they do? And what did I learn? And what might be the pros and cons? Just thinking through the opportunity to learn something differently. If your owner doctor is accessing a tooth within 3 minutes and it's taking you an hour, and your owner doctor says, I would use this burr, not this burr, that seems like a really legitimate suggestion, right? Well, they do it in 3 minutes and I do it in an hour. Maybe let's try what they do. So being open, that I think is incredibly helpful. Understanding that all of your doctors, endo works, right? Like endo works. So whether you do this irrigation protocol or that it's all going to work. So don't get so wrapped up and super textbook, because there are ways to increase your efficiency if you're open to doing things a little bit differently. Residency is a fantastic foundation, but private practice really demands flexibility, right? So not everything you learn in residency is always going to be applicable in private practice. You're going to have to think outside the box sometimes. So learning from the doctors that are already there and in practice, getting some mentorship from them, and learning how they might handle a situation different than you and why, that's all super relevant. And every office has its own system, right? So how we do things and how another practice does things, probably different. But but that's okay, right? But be willing to adopt the system. It's there. It's obviously been proven to be successful, or hopefully they wouldn't keep using it. So understand that there are systems and things that are going to be different, but be open to saying, okay, I'm willing to try this. Hopefully there's an owner doctor that's open to input if you identify something that could be even better. But don't plow into an office and be like, well, I think we should do it this way, because I think that they've probably gone through their systems and have found some efficiency there. So be adaptable, be flexible. All right, another thing that I have noted prior is that sometimes we're not considering the whole patient. So tooth number 19 gets referred and we just tunnel vision to tooth number 19, and all we care about is that one tooth. There's a whole person, right? There's a medical history. There's many teeth in the mouth. So don't get tunnel visioned. Look at the patient as a whole patient. And just because they referred one tooth doesn't mean there isn't more than one thing going on, and even on an opposite side. So it's your opportunity to be a very strong endodontist, potentially identifying more than one tooth pathology and being thorough for that patient. So I love that we use the Merida cone beam, and it takes a scout pan. And so scout pan, you get to look at the whole mouth, right? You get a snapshot. And my dental assistants are really well trained, and they look at that. Of course, they're going to image the tooth that they're referred for, but they're also trained to look around, right? And they might see, oh, that tooth's had a root canal on the other side. It has like a little darkness. They are encouraged by me to take another scan if they see something that they think looks suspicious. I will tell you, they pick up additional pathology all the time, all the time. Now, best case scenario, you identify additional pathology. That means additional treatment needs. That means preventing infection or pain for the patient in the future. That means comprehensive specialist and informing and letting your general dentist referrals know, like, hey, like we're considering and concerned about the whole patient. So it proves a lot of things if you are looking for other items. Of course, it's not same day stuff, but letting patients know this is something we want to address after this chief complaint. And then worst case scenario, if they take a scan and everything looks healthy, well, okay, everything looks healthy. But we all know very minimal radiation. So I think the benefit of my team potentially identifying pathology versus, another small field of view scan, I think the benefit certainly outweighs the risk. So making sure you're looking for other things. And then, not considering non-odontogenic sources of pain. I mean, we have, the world where if someone's having pain, it's got to be a root canal, it's got to be endo. And we as endodontic specialists see a lot of non-odontogenic pain. And so if you're testing and your radiographs and the whole thing is just not adding up, you have to be mindful or thinking that this could be something else, right? And you have to be very aware of that, because if you're just, again, to the tunnel vision, if you're just not considering all options, you don't want to be that person that does a root canal and 2 weeks later, the patient's like, I got the exact same pain, right? Like that's a bad day. That's not what we want to be doing. So if you can't reproduce their chief complaint and the testing is unclear, the appropriate thing to do is nothing, right? And I explain to patients, as of right now, I don't have enough information to be clear that this tooth has pathology or needs a root canal. Of course, I don't want to ever do treatment if it's not warranted. And patients are like, oh yeah, no, I don't want that either, right? So patients appreciate your honesty. And so sometimes it's like, hey, let's give it a little bit more time. Let's put you back on for 3 weeks, then we can have you come back and we can retest, or you could contact me sooner if things escalate or change. But patients really, I need to sleep at night knowing that I'm doing appropriate treatment. And then they also, want confidence that it's an appropriate treatment to do as well. So don't forget that we have oral facial pain specialists, right? So we have additional people in our fields that can be another resource to us. So I will tell you each and every time, middle-aged female with an autoimmune disorder, okay, they're just not like everybody else. All right. So if I see someone come in with fibromyalgia and blah, 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 and all this stuff and like 20 medications, I'm already really suspicious that there's, that there could maybe be something else going on aside from odontogenic. TMD presents as odontogenic pain very frequently. If someone's talking about burning pain, tingling pain, like weird stuff like that, that's not our world, right? So I would always use those resources and understand that a strong provider knows when to refer them to somebody else. So we're very fortunate in Charleston to have an oral facial pain specialist. She's the only one in the state and she's here. But I hope you practice in a place that has one, because a lot of times these patients, they just bounce around and they go see this doctor and that doctor and no one can figure it out. So it's really nice to have that resource. So I hope that you do have that, but be mindful, not all pain, and patients can swear up and down, it's here, it's this tooth. Then they get the root canal, then they get the extraction, and guess what? The pain doesn't go away because it was never the tooth. So those aren't fun situations. So just if it's not sitting right in your gut, like if it's just not feeling right, I would prefer not to do treatment in those cases. All right, I talked about this a tiny bit, but let's just not, we don't have to comment on the actual root canal. Sometimes I might gently say, I think there's room for improvement in this case, and, stuff like that. But like, we're not, you're just not dissing other providers. You don't know the circumstances of a case. So don't degrade other work, and just always having positive verbiage. That makes a big difference. Because we know, right, if we have the patient that comes in and is bad mouthing a doctor, that just doesn't feel well, right? It feels icky. And then what's to say that they're not going to say the same about me, right? And so we should always be very neutral when we're phrasing things with patients. It doesn't matter who did it. We're here to find out a solution. So just be very cautious about how you say things. I think that's very important. So we talked a little bit about expectations from a financial standpoint, but from a clinical prognostic standpoint, it's really important to be clear with patients. So if a tooth has a guarded prognosis, then that's important to discuss up front. And I have very, very clear, concrete conversations with patients, especially surrounding cracked teeth, right? So this is something we see all the time. You should have a cracked tooth soliloquy, if you will. You should have a process of explaining what's going on, so that patients can understand it. And, I'm always very clear with the patient that, a tooth with a crack has a more guarded prognosis compared to a tooth without a crack. That doesn't necessarily mean we shouldn't treat your tooth. And I kind of, go into that conversation, but I'm never going to disregard that part of the conversation, because we don't know which tooth is going to be successful and which one will fail. But I will tell you that I have never, ever had a patient who has a cracked tooth and it fails, even if it's 3 months later, right? One of those failures that happens really fast, patient never relieves symptoms, whatever it is. They never come back squawking or wanting their money back or whatever it is, because we had a very clear conversation about the tooth, about the options. And they knew going into it that I couldn't promise, that it would be successful. And so they made that as an informed decision. Now, if you have a crack and you don't even talk about it and you say, all right, let's go ahead and do treatment, then you're going to have maybe a grumpy patient if it doesn't work, because they'll be like, well, why didn't you tell me about that? I didn't know. So you got to be very clear, especially with cracks, because they just are so pervasive in practice that you really have to get that crack talk down. Super important. And then, of course, expressing need for crown after, very important for them to understand that as a follow-up step. I'm not, like I said, I'm not going down into the rabbit hole of risks and all of those things, but if I am concerned, if it's not a tooth that I look at and it's going to be a slam dunk, I always discuss with the patient. I also do this for really calcified teeth. And in my world, a really calcified tooth is like concrete. Okay. But if I know that going into the case, I'm expecting calcification and a more challenging access to the canals, I will preface that with the patient before we start. Because if I say to them, and I could show them on an x-ray, so you see this tooth, how you have a black line on this tooth, that's a typical canal space. And you see the one we're working on, you don't really see a canal or a tunnel there. That's because your canal is very small, very calcified. So all that means is just very small. We are going to take our time. I feel confident we'll find the canals, but we're going to be moving cautiously and doing it slowly. You're going to feel me kind of pushing around, right? Because we do the explorer push around to find the orifice. And so I tell them that before I start, because that's a weird sensation for them to feel. And they might be sitting there being like, oh my gosh, is something wrong? Like, what is she doing in there? But if I've had the conversation before we even start, then they're like, oh, she told me she's in there. She's hunting around for these little canals. And when the case takes longer, I told you going into it, right, that this might take a little bit longer than a tooth with open canals. So I think if you can set those expectations, now, you know, really understanding what a real calcified canal is important. You know, very few cases in my mind are, you know, calcified. But yes, setting the stage, setting the expectations so that if it takes you longer, the patient understands why and doesn't get frustrated or antsy in the chair. All right. And then patient-friendly language, you know, just using communication that your everyday person can understand. We don't go into periodontitis. And I mean, they just frankly don't understand it. It creates a little sense of unease for patients, and it's not helping them confidently be, you know, understanding of what's going on and what to expect. So just using patient friendly. If you can't say to just you know, a friend of yours the word and they understand it, then you shouldn't be using it with patients. You should find a different description or word, and not technical jargon. And we all do that. But, you know, even rotary, like saying, oh, rotary, like they don't know what any of that is. So, you know, I call them like sophisticated pipe cleaners, right? Like, I mean, everybody knows what a little pipe cleaner is. So, you know, just things that they can relate to. You know, I wouldn't say hypochlorite. Like most people don't know what that is. And I don't even know if I want them to know that I'm using that in there too. So antibacterial rinsing and, you know, just finding words to replace our clinical words, I think will make your communication with patients in general easier. All right, y'all. I think this is the last little section, and then we'll get to some fun questions. So business and practice pitfalls. So you're not just a clinician. You are a part of a business ecosystem. So I know we're trained to be clinicians, and we're all probably clinicians at heart, but we have to recognize and understand that the endodontic practice is absolutely a business. And so there are things that we have to be mindful of as a doctor in a practice. So, you know, not having a fundamental understanding of the economics of the practice, I think is, you know, a pitfall, because you should, as a doctor, understand some production goals. What are the scheduling goals for the practice? What is overhead, right? So if you're just like ordering all the things, like you're not understanding what the practice is trying to achieve, what an appropriate overhead is, what percentage of revenues should be attributed to dental supplies. Like those are all things that as a doctor, you should start to get some fundamental understanding of. Certainly time management is a huge thing. So understanding that if patients are waiting and you're not being on time, that affects the practice, certainly from a efficiency standpoint, but also, you know, patients want their time respected just like we do. So time management is very important. And then I would kind of put into this, like, you know, people that just live in a comfort zone forever, like coming out of residency, you know, okay, we're doing 3-4 cases a day, but there should be growth and there should be intentional growth. And if you're still doing 4 cases 20 years out of residency, I might argue that you're not kind of pushing yourself to grow and become better as a clinician. So getting more efficient and managing your time better. Okay, so just alluded to this, not staying, like, big pet peeve of mine. If I have a patient that is waiting more than 5 minutes, I get sweaty palms. Okay. Like that is a pet peeve. I think it is an incredibly poor representation of customer service. We've all been in a waiting room for a doctor, medical provider, whatever it is. And you are just like, really? Like my appointment was 52 minutes ago. Like that's rude, right? It's rude. And so you don't want to be that practice and you don't want to get that reputation. So you really have to be, I know what time it is all the time. Okay. Because I'm going to stay on time. I know exactly what time my next patient is showing up. I am very well aware of, okay, I probably have 12 minutes left in this tooth. Like I'm just constantly being aware of it because our patients deserve respect of their time. Our time is not more important than theirs. And I think if you treat as such, patients truly appreciate that. So if you are running behind, I'm not saying it's never going to happen, but for number one, acknowledge it, right? Have your team say, Ms. Jones, thank you so much for your patience. We are just running a couple minutes behind. We are going to be right with you. Can I offer you a coffee, right? Like being aware, like this isn't like we're pretending that we're not, running behind. Acknowledge it and apologize to the patient. And not for nothing, we have a bunch of $5 like Starbucks gift cards in our office. And if a patient has to wait more than 10 minutes, they're getting a Starbucks gift card, right? We apologize for any delay. We respect your time. Here's a gift card so you can have a coffee on us. $5, right? No big deal. And the patient feels appreciated. So being mindful of time, one of my biggest pet peeves, you just got to be on it. You do not want to run behind. Now, this doesn't mean that you might not have 25 minutes left in a tooth and you don't want to close up the tooth. And I don't blame you. You can finish it, but you still need a little bit of time, but the patient is ready, right? And so, so what do we do in that situation? Well, the patient not waiting has your whole team involved in that process. So it doesn't mean that you have to be ready that minute, but that's why you have your whole team. And so hopefully you're doing time studies in your practice so you know how long it takes for your individual team members to do their process. So what I mean by that is your dental assistant, welcomes, takes the patient back, takes the cone beam, sits and does a history, takes their PA, right? So that takes time. So maybe that takes 15 minutes, okay? And so I'm in the tooth. I know like, this was a tough tooth. I need 25 more minutes, but I don't want to close up the case. I really want to finish it. So I might, if the appointment time's at 1, I might allow to go over like 3 or 4 minutes. So it's 1:04. And so the patient's not grumpy, right? That's 3 minutes. They're okay. My team all wears headsets. I do not, but they do. And so I'm communicating when I want them to take the patient. So I'll say to my current assistant, they can work up the treatment. She radios to the team. All right, you can go ahead and work up the treatment. So then my dental assistant takes the team back. That takes them, like I said, 15 minutes. And then I'm, of course, working the whole time, right? So I'm making progress on the final steps for the case. So by the time they've sat the patient, done all the things, chit chat, and we might even say, we need a couple more minutes. So then they have the conversation of, well, what are you doing for Thanksgiving? Are you traveling next week? Blah, 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 blah. And so an attended patient is not a waiting patient, right? So if they're communicating with your team, if they're looking at your comfort menu, if they're asking questions, they're not feeling like they're waiting because they're not, they're engaged. And so even though it's not my time and I might personally be running behind, they don't feel like that at all, because the team is doing their part and the patient has moved from the reception area through the process. So they feel, right, like the process is moving along. So think through that. There's lots of ways to kind of like buy a little bit of time if you need it. I don't think the answer is closing up a tooth. If you can finish a tooth with less than 20 minutes, there's no part of me that is ever going to close the tooth and have the patient come back, because no one wants to come back. But I want to be respectful of the next patient. So you have to kind of learn those tips and tricks of how to use that time to have nobody feel like they're waiting. And that's an art too. So stay on time. Now, if it's going to take you 45 minutes and you got to close the tooth, like that's just rude to keep someone waiting. Okay. All right. Super important. You got to refer the patient back to their general dentist, right? So after a case, going over post-operative instructions, again, going back to expectations, very important to communicate to your patient about what to expect. So if they came in and their chief complaint was temperature sensitivity, I can look the patient in the eye and say, this tooth will never feel temperature again. That's great, right? But if they came in and their chief complaint was biting sensitivity, I can also say to that patient, biting sensitivity is a slower thing to heal. This will not be perfect tomorrow. It's going to get better each and every day, but it is not an immediate resolution of your symptoms. So by preparing the patient for what really is going to happen next in their world for the next few days, then number one, when they wake up tomorrow and they chew and it's still a little sore, they're going to be like, oh, yep, she told me that. She told me it's still going to be sore. So number one, they're not alarmed. They don't think something's wrong. They don't think you did a crappy root canal, right? Like they were prepared that that would be the case. It'll also cut down on calls to your practice. Like, hey, I had a root canal yesterday. It's still hurting, right? So you're going to minimize those things because you educated the patient before they left. And then you're also going to say to them, you know, I put a temporary restoration in your tooth. You have to get back to Dr. Jones within 30 days. Very important for you to return to him so they can put a permanent restoration in the tooth. So verbally telling them what their next step is. So they're like, okay, I'm done here. Now I need to go back, right? Because it can be very confusing for patients. So making sure you're setting them up for the next step in the process. And then, of course, I put this all in writing because patients only retain a small portion of what you say to them. So you verbally say it to them, you give it to them in writing. And then my team always does what we call wellness checks to check on the patient the day after treatment. And we're reinforcing those same kind of ideas with the patient. Now, don't forget, call Dr. Jones and get back with him, you know, just to make sure that the patient understands what is expected of them. The most frustrating thing is a patient that comes back and 6 months later and they're like, well, you never told me I need to go back. I told you, and I told you twice, and I told you 3 times, you know, but if they don't hear it repeatedly, sometimes they aren't absorbing what you're saying. So making sure they have to go back, closing that communication loop. Of course, you're going to send your final report to the doctor. So everybody should be on the same page. So making sure they know they have to go back to their dentist. All right, we're one down, y'all. All right, so endodontic success is built on relationships with your team, your patients, and your referrals. It's all about relationships, just like everything in life, in my opinion, it's all about relationships. So certainly, we should never, ever overlook the importance of the patient experience. I don't know why customer service isn't super ingrained in medical and dental. I think that's short-sighted and I think it's unfortunate, but we should be looking to wow the patient. I'm not talking just be nice and everybody be friendly. I'm talking wowing patients. And if you can figure out the simple ways to do that, your practice will stand out and they will go back to their GP and be like, oh my gosh, that office was great. They were this and that and blah, blah, blah. It's not, you know, everyone coming to get a root canal thinks it's going to be terrible, right? Let's be frank. So the bar is set so low that it's not hard for us to, you know, impress patients because they thought it was going to be terrible. And then it turned out to be wonderful. So really understand the patient experience is very important, especially for specialists, because we don't have that, you know, repeated rapport with patients. Really, if you're not considering how every interaction affects the referral relationship. So, you know, some of what we talked about earlier, but being very cognizant of everything we do is either strengthening our relationship with a referring office or weakening it. Difficult conversations, they need to happen, right? The 10% conversation. So, you know, sometimes we have conversations with people in our lives, whether they're work related, home, it doesn't matter. We're kind of saying 90% of what we're saying, but we're not saying the last 10%. And the last 10% is the meat, right? Like that's what the real conversation's about, but we dance around it. So difficult conversations, conflict, right? Everybody thinks of conflict as a negative thing. That's not true. Conflict's a part of life and it can lead to a lot of positivity. So, you know, don't think of conflict or difficult conversations as a bad thing. It's important for our growth and to improve. And then making sure we're collaborating, right? So to improve systems and patient flow, if there's something we can be doing better, like let's collaborate and talk about it and what can we do better. So making sure you're open to receiving this information. It's not criticism, it's an opportunity for growth, and to be able to professionally relay it as well if it would benefit the practice. So some key takeaways from today include communication with confidence and care, staying curious and adaptable, right? Getting the foundation from residency, but being open to learning more and different outside of residency. You know, understanding that you really are a part of a business ecosystem, and it's important for you to have some foundational understanding of the practice and the business so that you can contribute to that positively. Prioritizing relationships with your team, patients, and referring offices. It's all about the referral relationship. And then learning from mistakes. I mean, you know, you might look at it as the more mistakes I make, the more I'm going to learn and the faster. So you need to fail forward, right? You need to fail forward and gain something from each and every experience that doesn't go well. All right. So I know I yabbered for a minute.
We do have a couple of questions. The first one goes kind of back to earlier when we were talking about the circumstances in which we would refer to oral and facial pain, and how often are we doing that?
Yeah, so I think it is something, I'm trying to think if I can like quantize it. So, I mean, I probably send a referral to oral facial pain every month for sure, I would say. I don't think it's infrequent. I do think it somehow comes in waves sometimes. I don't know why that would be, but it does seem like, you know, don't send any for a bit and then I have a few in a week. So I don't know, maybe it's the moon, who knows, but sometimes they do come in patterns or waves. I feel like this is a little bit of an experience thing, right? Like, so I've treated enough teeth and I've seen enough cases that like I identify this just doesn't feel endodontic. Like I don't, you know, if I can't reproduce it, the sensitivity if it just isn't aligning, it's just not happening in my world. And so, you know, recognizing some of the signs or symptoms that would maybe be outside of the realm of endodontics, I think is really important for you to be mindful of, aware of. You know, connecting with your oral facial pain specialist, if you have one in your community, I think is fantastic, right? So take that doctor to lunch if you can and say, hey, I'm an endodontist, you know, and I would love your feedback or perspective in your specialty of, you know, things of what could I look for that would be an appropriate referral to you. I think that's, you know, a really fantastic thing because you're opening up a relationship with that person. And not for nothing, once you establish that, you could always text them and be like, hey, I had this patient come in today. Like, you know, what do you think about that? Right. So it's a resource for you. So I think it should not be infrequently. If you're never engaging that specialist, I think you're overlooking, like I think it was Nick's door for whatever that said, like 12% of what we see in endodontic practice is not even an endodontic. So if that statistic's true, then that means pretty routinely we should be identifying, you know, the need for other specialty care. So don't get tunnel vision. Just because we're an endodontist doesn't mean that everything that comes to us is endodontic.
Very true. Next up, we have, how often do you encounter a calcified canal that can't be negotiated to full length?
Yeah. Honestly, not super frequent. I will say that if I can see a little teeny tiny dark line, I'm getting down it. Okay. The only cases that I'm like, are like full calcified, it looks like just pure concrete. Like those are a little trickier. And those would absolutely be a conversation with the patient. about we may or may not be able to get to the end of the route. I'm going to do my best, but it might not be a possibility. And sometimes if I really am concerned about not being able to negotiate the case, I talk about alternatives up front with the patient. I said, I'm happy to give it my best. And if I can't negotiate down to the end of the canals, I'm probably going to recommend an extraction because otherwise this tooth is unlikely to heal. So kind of having those kind of difficult conversations up front. Now, again, I'm not talking about small canals. Like small canals you're an endodontist. They're going to be every day. But I'm talking about really calcified canals that warrant you having a specific discussion about it. And then here's my little plug for calcified canals. If you have never worked with or discovered the 12.5 C file, okay, 12.5 C file, the little red file, you have to find it. You have to find it. Dentsply sells it. I know other companies sell it. But if you are messing around in there with 6 and 8 files, you're wasting your time. Okay, because you get down there and you bend it, you throw it out. You get down there and you bend it, you throw it out. I mean, it's the most irritating thing in the world. And the reason is because the file is not stiff enough, big enough to apply some pressure, right? Like you need to get down those canals with some pushing and some pressure. And so I find that the 12.5 C file, you can push on that beast, right? You can give it some oomph and it's going to find that pathway and it will get down there way faster than those teeny tiny canals. And so, kind of making sure you have the right armamentarium. You have to be very confident in your access and drilling, right? So if you don't even see on your cone beam beginning of a orifice or something for say 10 millimeters, then there's no world where you should access 6 millimeters and looking around. It's just a waste of time, right? The canal's not there, it's way down there. So just being mindful of your measurements and how far down you are, the experience of being comfortable kind of getting down in there, with your anatomy, knowing where you're going. But I would just say, if you don't see canal for X amount, you should have that measurement, because why are you pushing around and drilling a little bit and pushing around? You got to get down there or else you're never going to find it. So yeah, calcified canals, they're frustrating sometimes. Hopefully you're joining a practice in a demographic where that's not all cases. So don't go to a retirement community in Florida, maybe. That doesn't sound like a great place to practice to me. You should be asking the practice or the doctor that you're joining, what kind of cases do you see? They should be able to tell you up front. My practice, we see 85% initial treatments and about 15% retreat and surgery. That's pretty great, right? That means 85 out of every 100 cases, I'm doing a root canal and I'm not retreating or I like surgery. But anyway, you know what I mean? You should know the quality of the cases you're getting. If someone says to you 70% of my practice is retreats, I mean, that's not fun, right? So knowing the kind of cases you get, do you get a lot of calcified cases? Again, what is your demographic? If they're our average patient is 40 to 60, great. Those are not calcified teeth for the most part. So knowing your demographics, asking the right questions. It's impossible to avoid calcified teeth, but you certainly don't have to set yourself up for a demographic that is going to potentially be incredibly prone to that all the time. So asking about the demographics and the types of cases a practice sees is important. And then I found clinically, sometimes, the cone beam shows nothing and you're like, this is terrible. And clinically it's better, right? So sometimes it's not as dreary as the radiograph shows. So I'm always game to try, because sometimes you're pleasantly surprised that it's maybe not as bad as it looked. And you just got to do them to get more comfortable.
Very good. Well, next up we have, with our written post-op communication, do we have a standard form or do we customize or adjust them to that patient? I did go ahead and proactively pull a copy of our post-op instructions. I'm sharing in the chat right now. I will comment, for us, simple, crisp, easy to read, And of course, always on brand in our practice, which is purple, something that the patient will go, honey, where's my purple paper with what I need to do? Our team does also wellness check every single patient the next day, just to check and see how they're doing. And they are educated to talk through when they're asking patients, how are you feeling today? They know what to listen for what's normal or not. Of course, if that patient is still a little bit sore, but feeling better than yesterday, they are going to encourage them to continue on their ibuprofen, Tylenol every 600 milligrams every 6 hours, rotating that for the next 72 hours. And all of those instructions are on their page that reinforce what we're saying. That's super helpful. If we knew it was a particularly tricky case or a surgery or something like that, our team is also trained to address that with them. But usually, going back to what Dr. Estes was saying about education, that patient, again, will wake up. If they had that biting sensitivity, they already know that might still be a little sore. So having that conversation with them of what to expect. Not sure if you have additional comments, but our team handles a lot of those post-operative instruction discussions and wellness checks afterwards.
Yeah, I would say post-op instructions, we do not specifically tailor it to the patient. I strongly emphasize ibuprofen and Tylenol. And of course, there's going to be the patient that's like, I can't take ibuprofen. Okay, so like my doctor doesn't let me take it, right? And for the record, from a pharmacist who came and did a fantastic education seminar for all of my referring offices. According to him, the only circumstance for which ibuprofen is 100% contraindicated is ulcerative colitis. That's it. That's it. Not high blood pressure, not pregnant, none of it. Okay. So if there's an extremely acute situation, he's like, everybody in the world can take 3 days of ibuprofen and be fine. Now, if it's a case, very mild symptoms and the patient's like, I can't take ibuprofen, I'm not arguing with them. I'm not doing that. Then I say, our post-op instructions emphasize ibuprofen and Tylenol. If you feel more comfortable taking Tylenol, I think that should be sufficient. If I don't feel as though ibuprofen and Tylenol specifically will resolve their symptoms, I do sometimes provide a corticosteroid, so case by case. So that's not on our post-op because it's not routine. We do at the bottom of our post-op put a next dose. It's like written on the bottom, which I think is a really nice touch. I do love to do a pre-operative ibuprofen regimen with patients because we know that there's going to be a little bit of post-op soreness. So we have them take a 600 milligram ibuprofen prior to initiating treatment. And then, so if my team gives it to them at 2 o'clock, they're writing down your next doses at 8 o'clock because they're going to go home and they're going to go, oh my gosh, what time's my next dose? I forgot, and it's going to be right on their paper. It's going to be right there. Making sure it's not like this big, huge paragraph, like little digestible pieces on your post-op form, because patients are not great readers sometimes. So you got to make it simple and easy to digest.
Very true. All right, you are going to just love this next question.
Bring it on.
And I can probably dig out for you while we're chatting about it. Okay, what verbiage do we use to explain a perforation in our informed consent? And also, if it does happen, what do we say at the end of the case?
Yeah. The perforations are not fun, as we all have attested to, right? Like it's just a very unfortunate situation. It feels terrible. It's not great. Now, a lot of times, so the very first thing about perforation is making sure you're identifying it clinically immediately, right? Like timing matters, right? So we know the location, the size, and the timing of the perforation is what is going to dictate the outcome. So if you have a perforation, you better know you have one, right? Like that's not good unawares because then you can't immediately repair it. So understanding it's occurred, okay. And then timely repair. So you should be putting your putty and repairing it. If it's, in my opinion, small, handled very quickly, I will tell the patient, your tooth, whatever the scenario, I'm not lying. I'm just like trying to put in patient words of your canals are very, very tiny. Hopefully I've prefaced this before starting the case, right? So I've already prepared them, tough tooth. And while I was looking for your canals, there was a small communication between the inside and the outside of the tooth. I identified it right away. I put a really nice reparative material in there. I don't expect it to have any impact on your outcome. Like, that's my conversation. I'm not dramatizing it. I'm not saying something. I don't think that's the right thing to do, but I'm saying this is what happened. There's a communication between the inside and outside of the tooth. I identified it. I repaired it. And studies show if you identify and repair it quickly, it should have minimal impact on outcome. And that's true. Now, if it's a massive, something, then you might have to have a more deliberate conversation in that circumstance. But honestly, as endodontists, we shouldn't be having those things. And if and when you're getting deep into the tooth and you're not really sure where you are, you stop, right? Like, you don't need to see blood before you stop. Like, you stop. I often, not often, but like earlier on in my career, I would take intraoperative cone beams, right? So if I've accessed and it's just a little bit unclear of where I'm at, I will stop. I will put, something that will be radio opaque. So I often put calcium hydroxide. So if I'm like, I think the canal's here, I will put a very intentional, specific dot of calcium hydroxide. And then I will go and have my team take a cone beam. So then you can literally see right where that spot is that I'm focused on. And you can see where is the canal in relation to that. So it kind of just, reorients you, puts you back on track. And then you can going or adjust a millimeter this way or that way. So don't neglect your intraoperative cone beams. They can be quite helpful. Through crowns, sometimes a little more challenging because you can't always see with the crown, but still can be helpful. And then what I would say is if you're just disoriented or you're tired, it's your last case of the day, it's been a busy day, you're tired, sometimes you stop. Okay, don't going, just don't feel confident in the direction it's going. Close the tooth, say to the patient, I do need to see you back. I haven't found your canal yet, but I think we're at an appropriate place to stop and I would love for you to return. There's a lot of benefit in getting a night's sleep, getting fresh eyes. I mean, the number of times that I've reopened a tooth and I'm like, oh, it's like, I just was a millimeter off, like, right? But at the time when you're tired and, just keep focusing on the same area over and over, sometimes you're just not in the best headspace. So don't overlook the importance of sometimes you just have to come back to it. So before you perf, take some measurable steps. But yes, preparation is included in our it's an important part of, that process. But again, I think being clear about it, using words they understand and not dramatizing it is what I would suggest for the conversation with the patient.
And of course, letting your professional relations person know so they can communicate to the referring office. It'll also go in your final report after treatment. But that's a big one. That's really important to make sure communication back to the office so that it's clearly explained what happened. Yeah.
Sometimes it's just a note in the report, like, but if I think it's a potential, impact on prognosis, then maybe I'm personally contacting, the doctor to have a conversation about it. And guess what? They've had bad days too, right? Like, everybody's had a bad day in dentistry. So, don't be fearful that your referring office is going to be like, upset. They're compassionate people too. I think picking up the phone and calling them versus having this big text chain, I think in that circumstance, a phone call is more valuable because they can hear your voice and you can hear theirs, and there's no interpretation of well, did they sound upset in the text? Did they not like, right? This is just a conversation, and be honest, like, you know, really tough tooth. I was looking for the DB canal, and, you know, hard to find, and the small perforation, I repaired it, blah, 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 right? Like, you're just owning up to it. You're communicating with them. They're going to say, I got you, right? Like, so they're not, you know, if they're a great partner or person to work with, they're not going to disparage you or think less of you. They're just going to be like, it happens, because they've had cases happen too.
Yep.
And if they're not supportive, then they're not a doctor you want to work with, right? I mean,
Yeah.
you choose your relationships.
Very good. Miss Madison, it says, what is your financial protocol for failed cases? So including the cases with a guarded prognosis, do we have a compensation policy if a case fails with a certain amount of time? Do we discount on retreatment or surgery if that needs to be completed next? Or are prices fixed regardless of outcome?
Prices are fixed.
Yes, they are.
You know, I know different practices might have different opinions on this, but in my opinion, I am very strong at identifying a case and its prognosis, right? So I'm having those very clear conversations up front. And the patient is making an informed decision. And I tell patients with a guarded prognosis, I'm like, there's no right or wrong in this situation, but we have two options. We can either do the root canal or you can have the tooth removed. You know, and I tell patients, I say there's a spectrum of prognosis, right? So there's excellent, good, guarded, fair, and poor, right? So there's people that fall along that spectrum. You know, unfortunately, based off of the circumstances of your tooth, this doesn't get that upper tier of excellent prognosis. It's certainly not hopeless, but it's somewhere in the middle. And, you know, what to do in this situation, this is exactly what I say to patients. I say, has a lot to do with your value system. And what I mean by that is I can have this same conversation with two different patients. And one patient might value certainty as a very important thing in their life. And so if you're someone that needs absolute certainty, getting the root canal is not an absolute certainty. The only certainty is to have the tooth removed. So for you, I would encourage you, if that's, you know, very important to you, certainty, I would have the tooth removed in this case. However, I have people on the other end of the spectrum that say to me, I understand what you're saying to me. I understand that it may or may not work, but I'm really motivated and I want to save my tooth. And so there are going to be those people that are like in the camp of let's try it, let's do it. Now you're going to have some patients that kind of hem and haw a little bit, and they're going to be in the middle. And so if they haven't made their decision by this point in the conversation, I will say, okay, you know, here, let's think of it this way. Let's say we go ahead and do the root canal, and hypothetically in like 18 months, your symptoms come back, you come to see me, and I tell you that the tooth needs to be removed. Right? So I'm painting a scenario for them. How do you feel in that moment? Are you totally frustrated, like I should never, you know, invested time, energy, and money, I should just have the tooth out? Or are you B, well, you know, we tried, that's unfortunate, but you know, now I know I have to get the tooth removed. Like, so what camp do you fall in? And when you present that hypothetical situation to a patient, oftentimes that clarifies for them how they really feel about it. Because I say to patients, I could do the same tooth in two different patients, right? It looks very similar case. And I could have one tooth that works for a patient and one that doesn't. And unfortunately, my crystal ball's in the shop. I don't know. I don't know which tooth's going to work. I will commit to you that I will do my very best with the case, and I'll do everything I possibly can to ensure the best outcome. But unfortunately, I can't tell you with certainty whether it will heal or not. And so because I have those conversations and I use those words and I involve the patient, I have never once in my 8-year career had a patient call wanting their money back. Never once. And I'm talking, it could fail in 3 months. But it's because I was so upfront and so candidly clear. Now, I didn't paint a terrible picture because you're going to get no patients, you know, to ever pursue a guarded case. But you really just have to figure out that balance of educating the patient, informing them, you know, if they ask me, what would you do? Guess what I would do? I would want to save my tooth come hell or high water. So I would pursue a root canal. If this were my mom, I would do a root canal. But that decision isn't true for everybody. But I will tell you, patients care very much about what you would do or what you would do for a family member. So if they're on the fence and really hemming and hawing, if I really would do this for my mom, then I say that to them. Like, if you were my mom, I would do the root canal. And they're going to say, okay, let's do it. Ironically, I had a dentist one time call me and say, oh, hey, we just saw Miss Smith back and the root canal you did 9 months ago. Unfortunately, fractured, or the tooth fractured, and they're having to have the tooth removed. And right, like what is the rest of, oh, well, aren't you going to give them their money back? And I'm like, oh, are they inquiring about getting their money back? And the dentist was like, no, I just thought. And I'm like, well, we had a really candid conversation about their case before we started, and they knew it was a guarded prognosis. And if they want to have a continued conversation, I'd be happy to have that. But it's not the patient. It was the dentist who felt like there should be this year guarantee. I don't know. I don't think there are any guarantees in life. And I did the root canal. I spent that time doing it. So I look at that it's cut and dry. They either committed to pursuing treatment with a clear understanding, or they didn't. And it's worked very well in my world that they never asked. If I do think that there might be a future surgery in their life or their world, I will say that, best case scenario, tooth heals. Worst case scenario, there might be a minor surgery in the future for this tooth. I say, but we won't know that until, the year recall, and we could describe it further then if needed. But no, it's again, so I think sometimes as young providers, especially, we feel some personal inherent guilt if a case doesn't heal. Right? So we carry this, every case should heal, and it didn't heal for us. Right? But it's that person's tooth, right? I didn't create the anatomy of their tooth. I didn't calcify the canals, right? We're working in an imperfect world sometimes. And so I will always do my best. But I think as I've matured in my career, being able to sit back and be like, I did my best. I don't think another endodontist could have done better. There were some challenges of the tooth and of the case and of the patient that are not a personal reflection on me. And I think you do mature into that. And so once you start to look at it that way, you're like, this isn't, I did a crappy job. Hopefully you're not doing a crappy job. But if you really did your best and the tooth needs a surgery, that's what the tooth needs, right? And so sometimes I think we should consider our medical colleagues, right? If a doctor does a back surgery and it doesn't heal and they need to do another back surgery, is there any world where that doctor is not charging for the resurgerizing? Hell no. Medicine doesn't do that. Medicine doesn't apologize for failures, and they certainly don't do anything for free. So I just think we could learn a little bit from them, because for some reason there's this dental world where, if we know that 92% of root canals are successful, that means 8% fail. So why isn't 8% acceptable for you and for me? I mean, unless we're not statistically relevant, which we all are, right? So you have to put it into context. I think you charge for everything you do, including your cone beam. You better be charging for your cone beam. That's not free services either. You don't get free medical scans at the hospital. Be proud of what you do. Be proud of what you offer. This is not oh, maybe we don't charge them for that. I know weird conversations like that happen in residency because you're trying to minimize expenses for patients. But, if you truly believe in the value that you're offering to the patient, then you won't have any qualms about what you charge, because you're providing value and a really great service for them. So that is my stance on that.
Sure is. And your team should be trained and educated on how to have these conversations as well. So they're not panicking, because they're going to be the one that picks up the phone when that patient happens to call, if it does come up, which again should be rare, but making sure your team knows to be reassuring as well. And Dr. Estes, that is the end of our questions list for this evening.
Nice. So practice pitfalls is not the only thing that should be considered. So our next topic of our webinar is going to be leading with purpose. So building a thriving practice culture. I know this is very near and dear to the hearts of Lisa and I. I won't kind of give away what we'll talk about in the next webinar, but leadership, like this conversation and practice culture, is not like fluffy woo-woo stuff. Like, I know sometimes people hear these words and think like, well, that's not super important in dentistry, or I want to talk about files. I don't want to talk about that, right? So, but I will argue that joining a practice that understands leadership and practice culture is going to be probably one of the biggest predictive factors of your success and happiness in a practice. So we're going to talk a little bit more about you as a leader in the practice, because every doctor, just from your title and your role in the practice, you are a positional leader. So you might be the newest team member, but the minute you walk through that door and you're Dr. Hicks, like, you are a positional leader. And how can you embrace that as an associate doctor or an owner doctor, whoever it might be? And then, how does that impact practice culture? And I think it's just one of the most powerful topics that we should talk about. So I hope you join me for that, because I think it's a very important conversation. That is going to be January, believe it or not. January is right around the corner. So we'll do another one at 8 o'clock on that day. Of course, if you have any questions or anything in the meantime, want to talk more about what we discussed tonight, I'm happy to do so. And I hope you had a good night and got some value out of today. But really happy you guys joined me, and we'll do it again if people keep liking it.
Yeah, thank you very much. It was wonderful.
You're welcome.
Yes,
Yeah, I
thank
appreciate
you
it.
for all the info, and see you guys soon.
You got it, Dr. Torkian. Have a great night.
You guys have a great night too.
Thank you, Dr. Estes. Appreciate it.
Bye, Madison. Have a good night.
You too.
Go save some teeth tomorrow.
Yes, ma'am. See ya.
Good night, y'all.